So one of the criticisms of everything that we've done so far, and of screening in general, is the lack of outcome data. And that presumably is going to be addressed by NIH. But I would submit that even if you don't have the outcome data, once you identify a patient who is at risk, and you still treat them on the basis of that risk, and if they don't do well, the problem is not with the identification of that patient, the problem is with the treatment. Because as this has been pointed out before, with the maximum 40% reduction in events by currently accepted standards, we're not doing that well. And I think the fact that we don't have that great outcome data does not mean that we should not pursue the identification of these patients and work concurrently on the treatment. And every day when we see patients with coronary disease, just with calcium scores that are high, and you say, why are they at risk? They have no sensible risk factors. So I think there's a tremendous amount about the atherosclerotic process that we really don't understand. In terms of the guidelines of looking at younger people, the question, again, relating to treatment is what do you do if you start doing biomarkers in somebody who's from the time they're born, or when they're 5 years old or 10 years old? What do you do about it at that point in time? You're sort of opening up a Pandora's box.
Early treatment? Well, as we know...
We're going to put a 2-year-old on a statin?
Well, in fact, the American Association of Pediatric Physicians, they recommended the statin for early age, as early as 6 months. And we're just looking at, well, even in those populations, you probably can find those who have perhaps better response to treatment.
Yeah. And that's been one of the issues with doing things like endothelial function at a young age. You'll find abnormalities, perhaps on a day-to-day basis, which may differ because of the responsiveness of the endothelium. What do you do about it?
So let's say if this is focused on identification of vulnerable patients, people who are going to have events in the next 5 years or so to make aggressive lifestyle change and modification in risk by exercise therapies that are effective, we would take care of the lowest hanging fruits, and then put perhaps less aggressive treatment for a larger population, which would go as early as 20 years. You know, American Heart Association has 20 years. So starting at 20, you will have to get to a cholesterol measurement every 5 years. That's the standard that U.S. Preventive Task Force approved and reinstated a few months ago. Every 5 years from 20 years, age 20.
We are discussing an important point to identify the people, and the comments were correctly, and I think very important, the family history to take into account when we try to subdivide the people who we are judging and possibly take into a test. I want to add one additional point, and that is what we learned from the marathon study, that we have to look also to the lifetime risk exposure. So when I talked with the World Record Championship of numbers of marathon runs, more than 1,300 competitions, I said to him, well, you have started possibly at the age of 20 years or 25 to do all it, because he was 70 when I met him. And he said, no, I started at the age of 39. And you know, we found, particularly marathon runners, more calcium, more factors of risk. And the possible explanation is that these people are working as crazy, smoking, obesity, up to the age of 40, 45, 50 years, and then they say, oh, I have to do something for my health. And then they change dramatically the other way around, and when you see them, they have ideal lipids, ideal blood pressure, and you think, oh, he's smart, low risk, but is of course at high risk because he had 30 years smoking and so on. So I think this point of history I want to strengthen.
30 age, that needs to be interpreted. Yeah. Okay, great.
One final comment. To me, one of the take-home messages of SHAPE is that treatment should never be initiated in anybody without either the demonstration of the presence of subclinical atherosclerosis, and it should not be withheld until you've demonstrated that there is no subclinical atherosclerosis.
Why would you say that? Don't we agree that if you have propensity for developing atherosclerosis, from your high extensive lipid, poor endothelial function, hypertension, and others, even if your chronic calcium is 0 or your chronic IMT is below 50%, and you're 25 or 30-year-old with all those risk factors, the burden of risk factors will fruit 5, 10, 15 years down the road, some atherosclerosis. Shouldn't we come up with one set of new guidelines that's still part of the mission of SHAPE? It's not as aggressive here, but put them also on alert that they will have.
On alert, yes, but on treatment, no.
Well, alert.
Because then you're just treating blood tests or risk factors and you're not treating a disease.
Well, that's what it is. The point is we're going to prevent the disease. They don't need to have lots of plaques in order to get the...
But wait a second, there's no data that shows that treating any person who is at very low risk makes any difference whatsoever. That data does not
It's
exist.
important to distinguish a 20-year-old from a 55 or a 60-year-old, and they're not the same animal. At age 20, if you have hyperlipidemia, it's worthwhile addressing that. At age 55, if you have no atherosclerosis, by at least 2 imaging modalities, and you have moderately elevated lipid, I agree with Harvey. There's no compelling argument to treat that lipid aggressively with no gain in the next 5 or 7 years. But that may not be true in a 20-year-old.
Okay, so PK, in a 20-year-old, you do a carotid IMT and it's totally normal. And he has the high cholesterol. What do you do?
But still, I think age 20 is too young to say that this patient is not going to have trouble in 20 years.
I think this is the scenario, perfect scenario for actually re-imaging these patients down
In
the
5
line.
years.
You could say 3 years, somebody with risk factors, and you could narrow that window depending on the age. So in a younger person, you may repeat it after 2 years, and a 55-year-old, you may repeat it after 5 years.
But it's the same principle.
Now qualify for treatment.
On the basis of the initial exam, you will decide whether or not to treat on the basis of the imaging, irrespective of the cholesterol level, right? And then you can re-image the 20-year-old 5 years later, and if it's still normal carotid IMT, you can say, okay, there's no reason to do anything.
Okay. We're going to come to the treatment part more, especially the lipid-related. I'm hoping Michael will take the active role in leading the discussion. Let's go back to diagnosis and the steps that we have here. Erling, what would you change here? What would you change from the step 1, age, knowing that this is focusing still on identification and saving the vulnerable patient, those 86% who came to emergency room and had never been told that they were at risk, never been treated, and boom, massive heart attack. We want to identify those, we want to treat them, and we want to be as aggressive on treatment as possible. What would you change?
I think I agree with Matt Budov that we need to focus on the population where it will make a change if you reclassify them in some way. And I think it should be clearer that in principle we should focus on the intermediate risk population. Because it's where you it's in fact the only population that don't receive a treatment according to the actual risk, none receive a correct treatment in intermediate. So if you can look narrow, I think also Greenland showed it in his American Heart Guideline statement paper, that in fact using coronary calcification, he could reclassify the intermediate risk group 1/3 down, 1/3 up, and there remained only 1/3 of the patients that did not receive an appropriate treatment. The other we don't know because it's not an outcome study. But I think we need to focus on, and it should be clear, an intermediate risk population. Then we also need to consider what to do with diabetes, and we also need to consider should there be an upper age level where we will not make any recommendation. Here we have excluded people above 35 and say they should receive unconditional treatment. Do we still have the same opinion now? Many people say you should not treat older people, and we say here all of them should receive unconditional treatment. So I think we also need to discuss the upper age threshold.
Yeah, the upper age threshold was, again, a cost-effectiveness limitation. That is, perhaps you should, I agree with you, if the treatment is not necessary, if they've been with these risk factors for so long and they survived it, perhaps they are the resistant strain and they're not going to really benefit from any treatment and they continue life and they die with cancer or other conditions. So the offer part, I agree with Erling that we weren't very clear.
Let me ask a question of people who do imaging on a day-to-day basis. What is the prevalence of positive coronary calcium or an abnormal INT in over 75? What is the proportion of individuals over 75 who lack evidence of carotid and coronary atherosclerosis on imaging? I think that might be better.
Yeah, the other way around.
Fine. Does anybody have any data?
Yeah, it's calcium
Let's hear it from people who have data.
Go ahead.
We have this data, but I'll present the data. But anyway, about 15 to 20% of people above 70 do not have calcium.
Do not have, what about carotid?
Zero.
I mean,
0% of people above age 70, and this is in prevention clinics, not the healthy population, have no measurable plaque.
so that would support the concept that over 75 do not require screening. They can be presumed to have a very high likelihood of having either carotid and or coronary atherosclerosis, right? If that's true,
That means
Your operation limit is correct.
so that means it is appropriate.
Exactly.
Exactly.
Because after that, you're always going to find everybody having
So if the prevalence of
But Erling's point is that, what do you do with those people? Would you say unconditional therapy, or are you
Yeah.
saying,
yes,
You will not prolong life, you will only change the way of dying.
keep
by
that in
swinging over
mind,
the-
let's keep that in mind. We're missing out, and I'm going to get this to Steve, but before that, just keep that in mind. We are also, we're focusing on heart attack and coronary, but doing a screening of carotid can identify people with significant carotid plaque for prevention of neurovascular events. So if you just leave it out at 75 and this guy has, 50, 75%.
No, but you are recommending that they be considered as high risk.
Right, but our risk is, we have local therapy, systemic therapy. We don't do the test. We don't know if I have only 1 millimeter plaque or a 4 millimeter plaque. And a 4 millimeter plaque definitely warrants an immediate, nexus step, whereas 1 millimeter plaque would just get on conditional therapy. So I think by putting that cap, we are missing a significant population that could be saved by screening for prevention of neurovascular events.
Now, I was going to say that what I'm going to tell you about is not unconditional therapy, it's conditional therapy. I call it treating arteries instead of treating risk factors.
Okay.
If I have a 70-year-old who has a lot of plaque for his age, I'm going to treat him more intensively. And if his plaque is progressing, I'm going to treat him even more intensively.
Then he needs to know that.
And if his plaque is regressing, he's fine.
Then he needs to know that. Then with the cap that we have, it's good for coronary because the treatment is systemic, but it's not good for neurovascular.
And to follow up on that concept, PK, when we see a 70-year-old in a clinic, we're not really thinking about screening. We're thinking about targeted decision. This is a person who has an elevated cholesterol and who would rather not be on a statin. We do the test to find out whether it's advisable that you're probably, if you have an unusually low plaque burden, we can say perhaps you don't need to be on a statin. So I think it's really not a screening. In the older people, you're right that the prevalence is very, very high, but it isn't like it's a positive test or a negative test. It's how positive it is compared to the other people in your
But
group.
that doesn't need to be in this element.
No, it doesn't.
Right, my point was, if the way we have it, it's fine.
Well, how do you say it's fine if somebody is 75 or 76, 77, and we don't have any clue that he has 60,
But that's
70%
not really identifying an asymptomatic subclinical.
Yeah,
if the prevalence, pretest prevalence is so high.
But remember, the goal of SHAPE was that identifying the atherosclerosis first, and then identifying the severity of the disease, and then matching the treatment to the severity of the disease, not the risk factor. But that's the point. We don't have that understanding of what is the burden of plaque and its carotid to a 76-year-old man, then we cannot tailor treatment to the severity of the disease.
They're already on treatment.
No, they're not.
They are.
Not necessarily.
You can't find me, there's no statistical way to have a 76-year-old person with Framingham who's not at least intermediate to high risk. It's impossible. You get enough points just for
But
being
remember,
76.
but again, I'm saying that we have two goals: identifying people who need to be treated, then match a treatment to the severity of treatment. Framingham doesn't have the match of the treatment.
That's fine, but more, you gotta restrict this to the population at risk. A 76-year-old person is not considered a target for screening by anybody. And the more you go beyond what is accepted by medicine,
Okay.
the more you're going to get
Then
pushback. Let's not fight a battle over a 90-year-old.
Let's ask
It's
David
not worth it.
and Spence, tell us how many people of the total neurovascular events that we get, which is very disabling and very costly, comes from 75 and older. What percentage of stroke and
It's very
severe?
high.
It's very high. It's probably more than 50% of stroke related.
Because they're not being treated.
Well, I don't think that's the question.
Right.
Everybody agrees
agree.
with that.
Well, how do we
The
change that?
question is they should be treated.
Right.
Well, how do we?
The threshold for treatment should be
No,
much
but
lower
the
than that.
treatment has to be
Correct,
matching.
Currently, you can only do a carotid scan on a 75-year-old if you get a bruise.
Right.
There are these guidelines, or, you know, if there is a
Or
TIA.
But that's so old.
If there isn't, then you don't screen them.
Right.
And you have an opportunity for preventing stroke.
That's what I'm
Yes.
saying. That's
So I agree with Moore that, we should probably have an aesthetic that for greater than 75, this is the algorithm we suggest, and that is to prevent neurovascular events, not necessarily.
That's right. It goes more towards neurovascular. Now let's see what.
But
that's not the
you achieve the
demographic.
same goal by treating them routinely.
Big picture, come on. More people die of heart attacks than strokes. Any age.
Right.
We're not going to go down this road of trying to prevent strokes only. Come on. More people die of heart attacks than strokes at any age, no matter what. There's no person, please, there's no demographic where more people die of strokes than heart attacks.
Yes, yes.
In general population.
In the elderly.
Elderly, more heart attacks.
No, man, that's not
I'm
true.
telling you, I show you age and data. AJ says more heart attacks than strokes.
Even if they don't die, the rehabilitation.
I'm talking about that.
Okay, that's
I think this is great. I agree with Dave. It's great.
let's go. Let's see. Go ahead.
The chairman needs to get control of the meeting.
Okay, Steve has the floor.
You asked about the prevalence of disease and David responded. This was a recent study yet to be published based on Black Hall's work in Spain. These are sort of the data they use to score as their risk calculators. And they went to shopping centers and screened patients on weekends. So what they found was rather dramatic. And again, using the plaque at 1.5 millimeter. Looking at the low and intermediate risks, people now, it was biased because they were in a shopping center and people come in who want to be screened, but it's not necessarily a medically driven group, it's just a curiosity group.
Rich people.
Not so rich. But it was free. But if you can look at the preponderance of disease in the low and intermediate risk group, rather surprised them. So I guess you asked the question, what is the preponderance of the disease in the elderly? 60 to 70 years old, very high, but it's also prevalent in the younger group too.
Okay, let's go and continue this discussion. We were going through the guideline and asking what is it that you're going to change. So the 75% just spiked the fiery discussion. Let's keep that in mind. Go down, George.
Yeah, my comment would be similar to what Jim and Matt said about with regards to the low risk, the step one, that I think if we recast that using, say, the Reynolds score that takes into consideration family history, I think that would be a reasonable step. My comments my more specific comments, I've got a very short presentation on obesity. And so even before you get to step one, the line that says apparently healthy population, my comments are about the apparently fat population. So we'll talk about that later.
Okay, great. Jim, what do you change?
I think, first of all, I think there's a mismatch compared to when SHAPE first started, where it was largely predominated by imaging people. Now we're seeing a mismatch between the contributors of biomarkers, genetics, and other things to what this guidelines looks like. So if we take away therapy for a moment, and something that I'm gonna make a case that maybe shape shouldn't be involved with setting target levels, or but that's for a later discussion. If I were to image somebody today, I would want to know a lot more than that. I would want to, first of all, know, is the plaque likely vulnerable? What do we have there? Second is, why does this person have plaque? This is all, before the LDL target level that you have. Why? So if somebody has a plaque burden that cannot be explained by conventional risk factor analysis, I get an LP-Lillet, I do other things. I have a different feeling about somebody with a score of 50 who's a diabetic or metabolic syndrome than somebody who's apparently healthy with a family history. So I think from the detection, the shape kind of guidelines, we could be looking at issues not only identifying plaque, having some comment about its likely vulnerability, how does it integrate with biomarkers and explanation of why the person has plaque, and then we can leave for discussion later whether we should be really dictating anything about LDL levels, not knowing the patient very well. And I think that's so I look at imaging as an opportunity in some people to be more aggressive than would have been predicted by Framingham, but I don't look at it as an excuse not to treat people. So a little bit different from Harvey's point of view, I don't use the imaging to ever treat anybody less than what conventional guidelines would have suggested, even though I know I'm going to be over-treating some people who have a 0 score. I use it as an opportunity to find new information that might influence more aggressive therapy.
Remember, we are going to be hit with the cost effectiveness issue. Right. So if you just go out and say treat everybody very generously, then the point is, and of course, we don't have data of 40 years of treating with the stat. We don't know what's going to happen to all other,
But my main point is to use the people we have now to make this more advanced as far as integrating biomarkers, genetics.
I think a very good point is that finding plaques and knowing that 50% of people after age 60 have plaques, well, it's not really solving the problem. What is the plaque composition, what's the vulnerability index, and so on. Irving, Peake, and I, we started with vulnerable plaque. That's how we came here. But we haven't progressed as fast, and this was a lot of intravascular plaque detection techniques which were not applicable to non-invasive. Non-invasively, we have CT and carotid ultrasound, and frankly, none of them has reached a level that gives us a very clear, virtual histology type. I've heard from Panasonic that there is something that they're working on, and others are working, but we should just open perhaps the discussions and welcome those developments to shape.
Or even non-technical. I mean, I'm looking forward to Mike's discussion on LP-PLA2 and how that might.
So systemic markers. Yeah. Okay, let's go down.
So I was just going to comment that, so far we've based everything on structure, which is identification of atherosclerosis. I think the next step would be, if and when those technologies become mainstream and become reliable and cost-effective, would be things like you mentioned, plaque phenotyping, one, genotypic or biochemical markers that further refine the risk. But I must say, at the moment, I'm not aware of any technology or any technique, biochemical, genetic, or imaging-based, that can be routinely applied to refine the risk beyond just identifying atherosclerosis. There's a lot of promising information coming, but none are ready for prime time. And we have to therefore be very careful. If we're advocating screening, then implicit in that advocacy is that something that's easily available, that's reliable, that can be applied across the board. I don't think we are quite there yet, although other presentations later might persuade us otherwise. But at the moment, I don't think we are there. That's a lofty goal, but I don't think we are quite there yet.
So as part of the shape two, we will recommend that those are things that we want.
PK, initially, it was all about the vulnerable plaque, and then there was a shift. Even those who espoused looking for the vulnerable plaque said, well, let's really focus on the vulnerable patient. And am I sensing that a renewed interest in going back to the vulnerable plaque?
No, it's X plus. It's like you have identified vulnerable, but still, vast majority of people with atherosclerosis still won't have an event. A lot of them won't have an event, even with atherosclerosis. So the question is, can we further reduce the funnel? You know, you're starting with this funnel, and you narrowed the list of patients who need to be treated to this. But there's still, the number of events is down here. So the question is, can we do better in picking out of this pool individuals who are really going to have an unheralded vascular event, which is what you want to prevent, is an unheralded. You don't care if somebody develops angina and then you identify. You don't want sudden death, sudden stroke, or an unheralded myocardial infarction. So that's the point, is can we take it a step beyond just structure that will give us a better discrimination?
So we had very robust data, though, for calcium scores at different levels, increasing robust data for IMT. Are you saying then that...
but still, what is the risk?
To further subdivide those groups.
Just about 15%, that means 90% are still not having events. So the question is, can we tease out?
But, you know, in many ways, I'm advocating knowing more about the patient, not so much the structure, although I think it's important, but more about the patient. Why do they have the plaque? You know, do they have Lp(a)? Are they diabetic? And that's why I think it's a little bit presumptuous for our guidelines to go into definitive therapy. I'd rather supply a referring physician or in a screening population more information about their inflammation status, if that's relevant, or the causative things, or the vulnerability of the plaque from a biochemical point of view, to the extent that we can do that, and less on therapy.
Well, yeah, and one thing in this, I see some people raise their hand, but Jim goes there, right there. If you don't mind, please raise your hand so we can go ahead. We want to get to the therapy part, Jim, later today. So we're focusing on the diagnostic part. Yeah, go ahead. Any comments on the existing shape guidelines of this side of the room that would result in any change?
I just would like to come back to the recommendation of the cutoff of the IMT, and 1 millimeter is really too much for early prevention. So I think that we really need a country-based reference value according to age, because a cutoff cannot be a cutoff for all the population. It should be adapted to sex and age.
I don't know if I'm mistakenly read it right. Where is 1 millimeter? We're saying you are high risk if you are more than 50 percentile. If you're more than 50 percentile, you fall into the positive category. And you could be moderately high risk, or high risk, or very high risk. So 50th percentile, sorry, this pointer is not good. 50th percentile in a lot of age categories would be way less than 1 millimeter. I don't know where this disconnect is. We don't have 1 millimeter as
yeah. 1 millimeter is really much over 75th percentile. And in a population of 50, even 50 to 60 years old, 1 millimeter is advanced disease.
Okay, this says carotid IMT less than 1 millimeter and less than 75 percentile. But here, we're saying, I wish Tasneem was here because she wrote this part. This one here, we're saying carotid IMT less than 50th percentile. So you're saying that you have a large group of people, or significant number, that would be carotid IMT less than 50th percentile and more than...
You know, based on an AREC study, for example, because that's the only reference values in the United States, the value was calculated on the basis of 12 points. Including common carotid artery, valve, and origin of internal carotid artery. That's not the recent ASC and Mannheim consensus concerning the measurement of IMT. So I think there's a discussion to have about what is the definition of IMT, where to measure, how to measure, and what are the reference according to this definition.
Okay, when we come to the IMT presentation, as PK just said, you'll explain to us what is it. But here we have 50th percentile as the cut point, not 1 millimeter. You have to be more than 50th percentile for your age category to come here, less than 50th percentile for your age category to that.
Yes, but if we don't have a reference value, we don't have 70.
We'll come to your presentation. Thank you. Let's go around the room. Any thoughts from the faculty for any change?
Well, just a brief comment, because there's been a monopoly of comments on this side, so I don't know what else I can add.
Take it away.
Oh, by the way, my name is Paolo, I can add that one. No, seriously. The one comment that I picked up on, and this is a debate that has been going on forever, ever since actually Tracy Callister and I published this idea of the percentiles for calcium score. I think that Raymond mentioned something. I believe you're probably right that absolute calcium scores predict better than percentiles when you're up there, not when you have a calcium score of 45 and you're a 42-year-old man. Then what do you do with that 45? That 45 is the 90th percentile of the individual. And I think that going along with the comment on IMT, going along with what Mo is suggesting, I think that we should keep the percentile idea, at least as a concept, to educate the individuals that are using these tools as to the importance of relative growth relative to the age and sex and race of the individual.
I have a number of comments. It's not my first meeting, so I don't want to be too presumptuous, but the thing that I think about scores, risk scores, I love Framingham, I love Reynolds. I developed a little pocket calculator for Framingham. Just doctors don't use them, and not just to our great educational efforts and lectures about it and so forth. It just doesn't work. I mean, so I think that an alternative approach would be to look at the age, and I would prefer to go down to 40, considering my brother had bypassed at 44 instead of 45. Women 50. Think about maybe different cut points, but to have the age, plus one of the following factors: family history, low HDL, high blood pressure, smoking, high Lp(a), metabolic syndrome, even waist circumference over certain inches, 36 or whatever you want to choose as your parameter, rather than Framingham or Reynolds risk score. And I think if it's a simple thing like that, you might get physicians to recognize it more readily. The patient walks in the office, stomach first, or something of that type that would trigger the need to do a more advanced imaging test or to make them a candidate for therapy. The other thing you may want to consider is, and this is, may not go well with this group, but if ATP4 comes out soon, next year, you may want to say for those who are not candidates for therapy based on ATP4, I mean, this is a way to bypass any controversy there, that you're not trying to in any way usurp the ATP4 guideline. This is ATP4 plus, basically, that you're saying anybody's a candidate for drug therapy, you wouldn't necessarily need a test. You would go ahead and treat accordingly, but as we're all aware, a lot of patients who do not qualify for therapy still are high risk, and Jupiter showed that very well. So I think to summarize, I would move it down to 40 for men, 50 for women. Have a checklist of things that would put them into a high risk category where a test would be indicated, and that checklist of things can be. When I mention it, and I think we should also maybe give a nod to genetic testing like 9p21, things that may be valuable or something that should be keep an eye on, and as evidence accumulates for the value of those type of tests.
Michael, while you're there, so we position SHAPE as doing two things in the diagnosis. One is identifying those who need to be treated. Two, matching the severity of treatment to the severity of disease. Framingham, Reynolds, or any other ATP4, they do the first part, assuming doing well, but they never have the ability to match the therapy to the severity of disease, because they don't measure the disease, they just measure risk factor.
Right.
So if we just say only ATP4 residual, then we don't deliver the goal that if you have, LDL, 100, 110, and it's still borderline, which is the majority of people, but you have a ton of plaques.
So that's actually a good point. Maybe we should say ATP4 high risk. Obviously we're not going to screen those, but maybe low and moderate risk, if they meet these other criteria, could be candidates for screening.
How do we know? How do we know the severity of burden of disease? We have no way of knowing it until we measure that.
So the question I have, which is, I think, let me ask the audience here too, when someone has a coronary calcium score of 30, almost everybody that I know is going to treat them as if they have atherosclerosis already, get their LDL below 70. I mean, there's a burden. In other words, a calcium score of 1,000 or 500 get treated different than a calcium score of 30 when it comes to the stress testing is differently. We're talking about therapeutic approaches.
Yeah, well, that is part of the pathways. You have 1,000, you fall into the very high risk, and then from there you have, you go for ischemia testing.
I'll put that aside for a second, but I would argue that anybody who's got atherosclerosis at this young age, between 40 and 75, whatever you want to say, deserves intensive therapy, maybe to the lower levels of LDL and non-HDL. So that would be a little bit different approach. I mean, it's not, so I don't know if you treated somebody with calcium 30 versus 300, you treat them differently when it comes to their targets of therapy. They both have disease. And it may just be the age difference, it may just be where they are in their disease spectrum that matters.
That's I think the percentile takes that into consideration, right? If you have a calcium score of 30 in a 30-year-old, that's going to be a very high percentile. And so that adjusts for that kind of disparity, and we agree, we would all treat that person very aggressively.
Right.
I think one point that he's bringing up that we didn't really very aggressively pointed out in his first SHAPE guidelines, that the severity of disease matching the severity of treatment is just here based on a few LDL points, and that is not enough problem. Frankly, if somebody comes here with coronary calcium 1,000, you have to give them a ton of warnings. It's not just their LDL needs to come down. They need to even take the slightest chest discomfort seriously, because they might, and when they go through the screening, the next step of screening for their ischemia assessment, I mean, that's right there. You find ischemia, you're going to have to put them in different categories. So
I was starting on step 1. I was a lot more to talk about step 2 and 3, but to step 1, I think kind of where Matt was going with the Framingham or Reynolds score, but I don't know. I think we should find a way to make it a checklist type of thing where people don't have to go ahead and do the score or go online and do the score. Just have a checklist of things that are likely to get to that score anyway. The other thing to keep in mind, Framingham and Reynolds too, we're talking about populations from 10 years ago, which are very different already today, with more metabolic syndrome and diabetes and obesity. And so unless we can adapt to that changing paradigm rapidly, we're also going to miss a lot of people that could still be at risk that we're not potentially screening with this type of testing. So that's why I'd rather have a checklist than the Framingham or Reynolds score, even though I'm a big advocate for those scores in general.
I want to add support your point of age. I think we have not discussed if you really start with 40 or 45 years and 50. Can we push this on? We did some calculations of the amount of calcium which you find in relation to different levels of blood pressure. Here you see for men normal, then the stage 1, stage 2.
Put it in slideshow.
Yeah. You see here we did this calcium scoring, and then concerning age, we plotted the different stages of the disease, and you see that we have normal, stage 1, stage 2, and hypertension. That's for men. My point is here that you see already at the age of 45, we have a separation of the different degrees of hypertension in relation to the amount of calcium. And when we then this is in men, and when we look to female, you see that the separation is not present, despite later big separation of the groups at the age of 45, but they start to separate at the age of 50. That would possibly support this point to think about if we really stick to 45 or 40 years or 50 years in men and women, and the similar results you find also when you look to the lipids. I think I have it here. Yeah. You see the lipids, we looked for LDL, and you see it in men. We have a separation of the groups in 45 years, and when you look now to women, it is separating really at the age of 50. And later, of course, much stronger.
Let's go down the aisle.
Well, I'm Ulf Näsler from Sweden, Umeå, up in the north of Sweden. This first time I'm here, and I'm a little bit confused. I haven't come longer than a step 1, I think, in my thinking so far. And family history is important. And the other point I would like to make is for identification, at least in Sweden, I don't know if it's the same in Denmark, cardiologists and general practitioners, they are already very skeptical of the risk scoring. They know about the overestimation and they don't use it so much. I think they put it down on the floor, despite the fact that it's green, yellow, red, and so on, and made in the best way to really understand it and to be simple with age and gender. So that's a problem. Maybe in step 1, the identification of patient, which is most important in the beginning. How do you deal with that?
I think the idea of checklist is a good one to make it more understandable and not make it black box for people. I'm really working on that.
We can have some optional checkbox things that people that want to, if people want to think about other things, that would be a consideration.
Robert?
So part of the discussion is what's new since Shape 1, and we'll talk more about genetics, but clearly it was only in 2005 when the technology, the gene chip technology came around, and then 2007 was when Bob Roberts and Decode came out with 9p21, and 2008 was pharmacogenomics. And the point of this is that it's all very recent and gives something new to talk about with Shape 2. The comments about the families I would strongly support, and PK said was a no-brainer or low-hanging fruit, and Matt's a co-author on some very nice papers from Mesa. The only issue is how you ask family history. And there was a recent paper just a couple months ago showing that the more detailed family history, the better the prediction. So that'd be something Shape 2 could take into consideration, is specifically what aspects of family history question do you ask, and give physicians guidance on that. Harvey's point I really support about lifestyle versus pharmacologic approach. And I'm not known for being a conservative, but this is one place where I think being conservative would be useful, and stay away from drug recommendations, but support lifestyle recommendations. The 75-year-old issue, I found a really interesting discussion because of Prosper. And we'll say some more about genetics and Prosper later on today. But in that study in older individuals using statins, that basically there was no effect, except for the subgroup of people that had a prior history of atherosclerosis. So if you look at 75-year-olds and above and you're trying to decide, should I put them on a statin for the rest of their life, if you have the history of prior vascular disease, the answer is it's going to help. If there's no prior history, the answer is it's not going to help. So would non-invasive imaging help you decide in that subpopulation of older individuals who do not have a history of vascular disease, is there vascular disease of a severe nature, and therefore they might plop into that subgroup. The gene test we'll talk about in terms of the risk-benefit balance for this whole radiation argument. So I think that's something that we'll get to in future lectures, but can we improve the risk-benefit ratio by incorporating some of these things and help not debunk but minimize the radiation aspect questions that have been coming about. The other issue is special populations. So should SHAPE 2 address special populations? I'll say some more about the National Firefighter Study, but you could go after populations that have an extraordinarily high risk based on their occupation. And that's very different from the general population. So should there be recommendations for firefighters, for example, mine workers, other subpopulations that have extraordinarily high risk for atherosclerosis in terms of when to image them and when not to image them. So those are just a few quick comments.
Very good point. Thank you.
Yeah, I just would make one point about, I think we might look at, particularly for the moderate and the lower risk groups, which is to focus on rates of change of items in the checklist. Now, obviously, the low risk group maybe have fewer items, but in particular, if we focus on looking at rates of change of these items, we can then even make some predictions as to how those might develop later on, even 5-10 years out. But it could help to identify and also to motivate those people to undergo things, basic things like lifestyle changes and so on, which could be implemented relatively soon.
That's a good point. And we're coming back there. This was one of the hiccups in the first SHAPE guideline when we were recommending how often these tests need to be done. We need to get back there as well. Do we really want to stay on 5 or 10? And actually, at the end, we were so tired of so much, especially we said, well, just leave it to the doctor. That's where we gave up on guideline, but we're going to have to go back and address that. Any other comments? You pass the mic. Okay, go ahead.
Is it possible to put this screen on?
David, could we change the one of these over there, or? Oh, is he plugged in? Okay. What would problem number 13?
So I had several comments, not so much about that algorithm, although the first one is, that was it.
Is that you?
Here's what happens to the black area. It takes off after age 40. And a little bit later is maybe. So there might be a reason to think about going down to age 40. The other comments I had aren't so much about the algorithm, but a couple of conceptual issues that have been discussed. I think vulnerable plaque is about surgical therapy. Vulnerable patient is about medical therapy. So if I have someone with asymptomatic carcinosis and they've got microemboli or interplaque hemorrhage, I'm more inclined to think about endarterectomy for that person. I don't know if that applies also to coronary disease, but it might.
Well, we don't have data for coronary intervention that much, but that's exactly the way that studies like Prospect are heading towards it.
So I think of vulnerable patients when I'm thinking medical therapy and vulnerable plaques when I'm thinking about surgical therapy. And then the other thing about people over age 70, and I'll talk about it a little later, there's a plaque for screening in these people, especially since I run a prevention clinic and they've already been referred for prevention. I use plaque measurement for treatment, and I'll explain it.
If we're talking about lowering it to 40, then we're going to be excluding many, many more patients because the age factor of the Framingham only kicks in at 45. So you're going to have many patients who will be lower Framingham risk who are talking about screening. And if you insist that it's a 6% Framingham risk, that excludes most people who are 40 to 45.
Yeah. Well, Matt, we're gonna have to address this issue that.
No, I like the other comment, the,
Checklist?
going to a few risk factors. I totally agree. I think nobody uses Framingham. I just wanted to get away from our current first recommendation, which so far exceeded the other recommendations that we got pushback from it. If we put in a risk factor, very low risk, as the only people we wouldn't put into shape, because then that means we're saying everyone applies to shape.
So
There's no way not to get into shape.
Harvey, do you think what percent of people between 40 and 45 or 6% would be left out?
Almost all of them. Because age is the biggest contributor to the Framingham risk score.
It'd be hard to get up to 6% at age 40. Now, even the plaque data that was just shown, though, women don't start going up until age 50. So I still think we have to discriminate by 10 years to be concurrent with evidence.
This may turn out to be our departure from Framingham. You know, Michael brought this checklist. You're saying 40.
This
might be with that 6% because it leaves out a lot of people, and he's showing here a lot of plaques in that age group. Any other comments? Okay.
My name is Itkar Blue. This is also my first time. I must say I'm awed by the intellectual brilliance in this room, but I still make the comment to Dr. Heckman that we don't know a lot about this disease yet. And so I think philosophically two issues. One, that it's so complex that we probably do need a multi-modality approach to it. The point was made about biochemical markers, genetics, and imaging. And the second thing that I've always been struck about is the temporal behavior of plaque, which sometimes we don't incorporate in our risk assessment tools. And that, you know, if you assess somebody once, he's going to be a different person a decade later or 5 years later. So plaque behavior is not linear, it's stochastic and probably non-linear, and we need some markers that address that. On a more concrete basis, I think the other concept would be of vascular aging. And incorporating, instead of chronological age, some assessment of biological age into the Framingham risk score. And one potential candidate is aortic pulse wave velocity, which I think is a very good marker of aging, and I'll discuss that in my presentation.
Okay, so you're actually saying, you know, if you look at the SHAPE guideline, actual guideline text, you see a picture, which I don't have it here, but it says, you know, these are risk factors on this side, these are markers of structural, and these are marker of functional assessment. That's where Pika was going. Right. We've so far focused on the structure. Yeah. We don't have data on the functional. And the very latest data I'm aware is what Jay Cohen's poster showed at ACC, that his C1, C2 measures were predictive of heart failure in MESA in completely asymptomatic population. And I think Tasneem, you commented that is true, but this is prediction of heart failure, not atherosclerotic disease. But don't we care about preventing heart failure as well as atherosclerotic disease? Well, Matt doesn't.
You can't do everything, Warren. It's not. This shape isn't the world. You just got to focus.
That's a good point. However, the point is, if they come to a preventive clinic and you have a tool that can measure pulse with velocity, or what would you say? Pulse.
Yeah, that's the best marker of arterial stiffness right now. I think endothelial function is still open to debate. Brachial reactivity is what's been used, but for stiffness, pulse velocity is the gold standard.
I agree with Matt that we have made our focus asymptomatic atherosclerosis, and that's really the title of our book that came out, is Asymptomatic Atherosclerosis, Atherosclerosis-Related Cardiovascular Disease. But perhaps in ending part of our thing, they say other things of a screening could also improve prediction, but those are not the focus of the SHAPE.
I think we ought to stay on the message, because heart disease is such a wide spectrum. We haven't conquered atherosclerosis. We should not get into heart failure and other things. I agree with Matt. Let's stay focused on the #1 killer.
Okay. Well, no, but
and what we're trying to prevent is not coronary heart events. We're trying to prevent unheralded
well, that's the focus of the first
that
one.
really needs to be that unheralded events. That the very first, we don't want somebody to have a sudden heart attack, stroke, or sudden death as the first manifestation.
But can we rule
then
out?
you have no opportunity to prevent it. consider credit. And that's really where the biggest bang for the buck is going to come.
I agree, that's the lowest hanging fruit, but can we rule out the value of adding functional measures, whatever is available?
I think we should wait till we listen to the presentation.
Yes,
where it fits, yeah.
As the communications person who actually assisted in creating this, I've always been amazed anybody understands it. So I'll just say, that's the long and short of what my contribution is just keep it simple.
Dan Berman. Along those lines, I completely agree with this simplicity of the risk factor approach rather than Framingham. I think we were too simplistic here by saying any risk factor, and that having a kind of a checklist that has to add up to something is the better way to go. But if we have to keep it simple. And if we do that, we will still end up being close to what will be tested in an age trial. It won't be exactly the same thing, but it'll be realistic and practical. I think we do need to consider the older patient over age 75. Even though we do consider them all to have disease, the intensity of the treatment is very different. And many of these people are at high risk, at very high risk, and don't know about it. And if we just simply treat them medically, we miss those patients. And we should address those. I think a group that we have not talked about, I just mentioned briefly, are the diabetic patients. It's a little off the course because we think of them as high risk, but in fact, diabetes is no longer considered a coronary heart disease equivalent. We've got data, and Paolo's published data, that about 30% of diabetics have 0 coronary calcium scores. And their risk over time is very, very, very different from the people with the high scores. There's benefit to that. I'm not suggesting they don't be treated at all. There's very great benefit to knowing that. So I think we ought to address the diabetics. And then in terms of the very high-risk patients, it may be the diabetics, it may be the people who have these high-risk occupations. We are down to such a low dose with coronary CT angiography that I think low dose and low cost, even though it's a little bit outside of our main emphasis, I think there are certain groups of people in whom we can better characterize better phenotyped patients with their plaque characteristics and the extent of their non-calcified plaque and mixed plaques that are really the more dangerous kinds of plaques with using that test, but only for a reserved group of the population.
That's a very good point. So CTA, I remember in 2004 we were discussing this, was very early day, and it was 16 the slides or 64. So where would you go with the next step of CTA here? Would you ever recommend in this population as well, or stay just in the very high-risk population?
It's complicated because it's going to be...
Just speak your mind, because this is very interesting. This is speak your wish list.
I think that it's not going to be possible for us to get to the point where anybody's going to be able to pay for screening of broadly with a CTA.
Even if the radiation was 0.
You just can't pay for it. We don't have to, but it's going to be cheap enough that it could be used in certain groups of patients. I'm suggesting that it might be the patients with the very high-risk occupation, and it's possible that it could be the diabetic patients. And I don't think we've figured it out enough yet to know, but I think we have to have
That's a good point. So a special population that Robert just referred to could be one of those categories. So diabetic could be that special population, firefighters, and so on. Okay, thanks, Dan.
Tasneem Naqvi from USC and very little from Cedars now. Okay, I have 4 comments about the table here and 2 about what we have discussed about the 75-year-olds and the functional imaging. First of all, I totally favor the risk-based approach instead of Framingham risk, or for that matter, ages that are outlined here. And I think we should also look into premature menopause in women as being a risk factor, besides all the others we just discussed. As far as the atherosclerosis test, I think we touched upon the fact that if somebody has a negative test by both imaging modalities, we are still calling them moderate risk, and we are recommending the LDL target to be less than 130. Now, even though we are not necessarily implying drugs, I think, we need to look into, discuss this point at least, to say that once they've been deemed low risk by 2 tests, are they still at moderate risk? Because now we are calling them moderate risk simply because of the framing simply because of the risk factors.
No, there is a which one?
The second one, this one, yes.
That's an excellent point.
That's a good point.
The second thing I would like to point out is, even though there have been studies that have come out, at least related to ultrasound and carotid plaque since our last guidelines, none of them are mature enough to incorporate into our chart. And I'm referring to plaque characterization, plaque volume, 3-dimensional ultrasound. However, I would like to have some differentiation about the magnitude or the burden of atherosclerosis. So currently we are saying no plaque or a plaque. Now, there is a big distinction in somebody who has one plaque, let's say in the bulb of 1.5 millimeter and nothing else anywhere else, as compared to somebody who has extensive plaque, all of them amounting to, let's say, 1.5 or more millimeter, but in multiple segments or calcification associated with them. I think we need to come up with a simple way of addressing the burden. And one simple way, I think, would be to say the number of plaques or plaque in all segments. So a CCA, bulb, and ICA, that's like everywhere, at the very least. I read Dr. Spence, your paper and your work, tremendous work on plaque area. I thought you were also incorporating IMT as part of plaque area, which is kind of something that's debatable whether IMT and plaque are kind of equivalent. But anyway, we can probably...
We have Henrik Sillison, who has the first 3D carotid